¿Se me oye bien? ¿Sí? Perfecto. Bueno, buenas tardes ya casi, ¿no? En primer lugar,
Good afternoon. First of all, I'd like to thank the organizers for asking me to chair this half-an-hour session. Let me introduce the panelists. On my right-hand side, José Baquero, coordinator of corporate social responsibility at OAFI Foundation, and on my left, Vicente Baixauli, president of the Spanish Association of Community and Family Pharmacy, SEFAC, with his pin here. I'm sorry, I do not know you. She's Maria Teresa, and she'll be participating.
Perfecto. Pues María Teresa también participará en la mesa. En primer lugar, lo que queríamos hacer, como saben, la mesa se llama...
And, as you know, the presentation, the panel discussion rather, is ARTRO360, and as a title, a new, more human care model. And now I'd like now to hand it over to Dr. Baquero. Then we have some questions for the speakers. And finally, I would like to hear about your participation, because we cannot create a model without giving the opportunity to patients to participate. Thank you very much. I will try in just 3 slides to tell you what ARTRO360 is about. This is a care model, a healthcare model, that wants to promote a multidisciplinary approach and treatment by optimizing resources. This is an OAFI-based initiative that has also been supported by 12 scientific and professional organizations, proving its worth, both medical, in nursing, and in the managerial side. There are a couple of things worth highlighting here. First, that this is a multidisciplinary approach, and secondly, on the significance in the patient's involvement in decision making. And what's the proposal here is to promote the participation of patients and practitioners in decision making on public healthcare matters, but also on research and management models, to promote the participation of patients in decisions that have an impact on them as being accountable for their health, then accelerating the diagnosis. You know that both AOP and OA usually take 3 years of a delay in being diagnosed, and therefore they are approached later, to facilitate access to ideal both non-pharmacological and pharmacological treatment, the sooner the better, but also considering the comorbidities, because we are not talking about pathologies, but patients with pathologies and then some others, they have comorbidities. And if you are focusing on the patient and not on the condition, you need to bear that in mind. You need to bear the multipathology. And then we need to raise awareness among the institutions and the public on the role of these associations, which are a source for information with real, truthful information, but also to support programs that often are not considered within the portfolio of benefits. So all patients should be interested into contacting with their patients' associations. And so far, we have talked about what would be the 3 main steps for the dissemination of ARTRO360. September last year, this was submitted before the Senate and received a broad political support. And this year, we are now focusing on raising awareness, both on the publications, on the new medical economics, and last week it was presented as a free paper in the SEAUS conference, the Spanish Association for Healthcare Users, and it will be soon introduced in the Madrid Autonomous Region. Then in 2023 we will be presenting it in Catalonia, in Valencia, in the Basque Country, and Galicia. And that was about it. Thank you. Thank you very much, Dr. Baquero. Would like people to participate from the very beginning, so if you have any questions, feel free. And I think we have microphones, roving mic is there. Let me start with Dr. Baquero, now that he has gone over what this model is about. Why this model? Well, we believe that we've been talking for long about the empowerment of patients and organizations, but what we have seen from the organizations is that this has not been for long. And precisely, we want to ask for this co-participation by patients on decision making. And unless you make people participant of decision making, it will be difficult that they adhere to treatment. But us as organizations, we can also be the people that can represent them on behalf. So it's a truly participatory role then. Yes, we have to move away from being paternalistic, as we were saying before. This enlightened nepotism in the 18th century, it was like all for the patient without the patient. I think that's obsolete.
Dr. Baixauli, what is the role of chemistry within this model of the 360 model? I believe that everybody knows pharmacy or the chemist because that's where they need to pick up the drugs prescribed by the doctor. But as part of this model, I think it's a model that can be exported to any systemic pathology. It's an exemplary model. In addition, this model already counts on other countries that are already implementing it. And there are some characteristics that you already highlighted. For instance, coordinated action. This is key. We believe the chemist is a healthcare establishment and it should be coordinated with the other stakeholders. That is, the other centers as part of the healthcare system. There also needs to be continuity of the healthcare assessment and care, coordinated manner, the participation of the patient, as you just said, and not just the patient, the relatives as well. The carer is very important. In most cases, it's usually a close relative. And in this regard, in the chemist, we are fortunate to know the patient and the family. And this makes it possible for us to incorporate this model and all the possibilities of the chemist when it comes to the entourage of the patient. There's something important too, prevention policies. I believe this is one of the pending subjects of our healthcare system, prevention. There is data that I did not know. In our osteoarthritis, 20% of women in our country already suffer from osteoarthritis after the age of 15. And this is something that should position ourselves about the importance of prevention, the modifiable risk factors. And in these prevention policies, the chemist is an establishment that is very accessible for people. And it could help, as part of this model, to facilitate the achievement of all of these goals that are legitimate goals, of course. How should we not pay attention to a disease like this, where there is such a high incidence rate on patients and which could lead to a disability with pain, with inflammation, you know? How shouldn't we not focus on this? How should we not participate in a model like this? I think it is clear that because of all these reasons, the chemist can help. Actually, the chemist is another healthcare agent that we need to consider, right? And how would SEFAC help patients? The first thing we did from the SEFAC was see how we could change the focus, the target. We are an association of pharmacists, so we do training, we do our things. But these things that we do, why do we do them? We do them for you, right? For the patients. Doctors, nurses, why are we all here? We're here for you. My job, as well as the job of my colleagues, doctors and clinicians, is a job we do for you. And if we do not do things well, then we're not doing it for you. So as chemists, it's fine. It's okay to be trained. But why do we get trained? For you. Let's channel think correctly. We've set up the SEFAC Foundation, which is patient-oriented. And through Dr. Vergés, we had the opportunity to clearly focus on this vision of the chemist focusing on the patient. And that is when we started to cooperate with OAFI. I am aware that some colleagues of mine already participated on the radio and other activities that you organize. And when the ARTRO360 model was presented, we had the opportunity, along with Dr. Vergés, to review this model, to get to know it, and in this respect, to become integrated into this multidisciplinarity that the model defends, to count on us all, on all the resources, and to work with a common goal, focusing on you, the patients. We refer to the patient, but they're always the last to know. This is one of the strengths, and we are fully aligned. We spoke about the ARTRO360 model. And one of the things that has been said is prescription, right? Pharmacological prescription, and the role of the pharmacologist in the control of the drug. Yes, I don't know whether you know this, but we cannot go to the homes because we are not allowed to. With COVID, unfortunately, there were many cases where the chemist had to go to the home of the patient. We've been demanding this to the administration so that in certain situations, we, the chemist, could go to the home of the patient. In any event, where can the chemist help? As part of this multidisciplinary model, I would say that when it comes to the drugs, we, the chemists, are specialists on drugs. So when it comes to the drugs used for osteoarthritis, you know this better than anybody, to reduce the pain, because the pain can be weak or intermittent, but it can also be chronic, acute pain, incapacitating pain, to the extent that people might find it difficult to carry out their daily tasks. But, as you well know, OA has many other comorbidities associated to it. There are many people who are hypertense, diabetic, with a pulmonary disease, and this means that usually people will need to take more drugs, with the final result that those who take more than 5 drugs are labeled as polymedicated patients, someone who takes a lot of drugs. And when one takes a lot of drugs, the probability or the likelihood of there being counterindications, or simply put, the fact of that I should remember taking all of these drugs at different times of the day, different tablets and pills, well, all of these things need some counseling, some advice, or at least training. You might know the tablet dispensers, right? That can help. And counseling on drugs, preventing adverse reactions caused by many drugs, and unless follow-up is carried out, unless talks are made with the people, many would think that these things happen by chance, and they did not. When one uses a drug, one should know what should happen. So all of this advice in terms of use of drugs and how to help patients to be capable of using them better to prevent polymedication, or if they are already polymedicated patients, to prevent adverse effects in relation to the drug, especially interactions, then the chemist can help. And Dr. Baixauli, you mentioned earlier, before we came here, that polymedicated patients tend to go at least to the chemist 4 times a month. How many of you go to your GP more than 4 times a month? None of you, right? So you're even a healthcare agent that it's much more accessible for us, right? Much more than the GP. Thank you. And what is the final benefit? What's your plan to disseminate it? Well, what we expect is for there to be joint participation and multidisciplinary participation as well. We want the administrations making these decisions about strategies to be followed, that is the ministry and the central administration and the autonomous communities. We want them to consider the professional, they are the experts, and the patients, who are also experts, actually experts that are involved. This is like the pig and the hen, or the bacon and the egg. How will you not consider that I am the pig, right? So this is something that seems to be legitimate. It is legitimate for us to claim our capacity to participate, but on the other hand, we believe that we contribute to making this system more profitable and more sustainable. A society that uses all of the resources will be much more sustainable. And patient associations contribute by cooperating with the system, by contributing with services that are not provided by the basic service portfolio. A large part of the psychological assessment and support, physiotherapists, nutritionists, activities of a sporting nature, Tai Chi, and also leisure activities, help groups, expert groups. These are things that patient associations can provide, and these things contribute to the sustainability of the system. And obviously, a doctor or a nurse in primary care that can dedicate some 10 minutes to us at least once a month, not like you in the chemist once a week, have no capability of doing a suitable monitoring that can be done from the community chemist and from patient associations. Now, if I may add, I would say that everybody knows about electronic prescriptions, but what not everybody knows is that the current electronic prescription is not bidirectional. It comes from the doctor to the chemist, and it says the chemist what they need to give. But the chemist knows what the patient is taking of that prescription, but they also know what the patient is taking with them of things that do not require prescription. There could be incompatibilities or interactions. The chemist, if they could go into the clinical record, and if they ask the patient would say yes, they could include very valuable information for the doctor or the nurse in primary care. I'm saying this because a lot is said about the electronic prescription, where the current one is not bidirectional, and it should be. Or even patients could have access to provide their medical record, because the chemist will better understand the treatment to be given if they are aware of the diagnosis. I'm not saying that they may change things, but they could provide valuable information for other professionals involved. So all of this is multidisciplinary, and that's the way it should be. And when it comes to distribution, right now we're in the stage of publications and presenting before autonomous communities. Multidisciplinary approach cannot be understood without bidirectional communication, right? Between chemists, professionals in primary care and other healthcare levels that can communicate for the benefit of the patient. I believe that is key, yes. Could I? Of course you can. Delving into that, bear in mind that since there is a GP, some people have private doctors. Not only do they go to the public health system, and the problem there is bigger because your medical records in public health are not shared with the doctors in private health. This is a problem. In the chemist, we can see it all, those who come from one side and those who come from the other side. And our hands are tied because we cannot get in touch with the doctor. This is a problem because you are the most affected. I see things that if I could notify to the doctor, I could avoid visits. But it is not there, it cannot be seen, it has not been renewed. Some things could be resolved much more easily if there was this bidirectional communication. And I always say we, the chemists, are not particularly interested in to see what others do. I don't know how to interpret X-rays. This is not my job. I have not been taught, and I don't want to. But what I can do is when I say that this drug does not need medical prescription, the doctor should too. The doctor should have that information. And this is something we cannot put. I don't even know if you are allergic to a drug, because I am not allowed to see it. And then you are the experts on the drug, and I, as a patient, would love if you could validate that treatment. It would prevent more than one medication mistake. Because a lot has been gained with the electronic invoice when it comes to prescription mistakes or errors. But you are true experts on the drug, and undoubtedly, if an expert on the drug reviews the treatment to be followed with that drug, will feel much better. I think this helps to improve things. As for drug prescription, I believe we have another role. When one sees the addresses and the amounts of drugs there are in these addresses or homes, that's something that we should do something about. One day there's one prescription, another day there's another prescription, things are left, and unless they're organized, one may find loads of drugs which are okay for one, but maybe for the partner, for the children, for the grandparent, they're not good. There could be mistakes, so this prevention of errors should be kept in mind. We need to review the drugs we keep at home. Go to your chemist and tell your chemist, is this good, is this not, can I take this, is this good for me or not for my husband? This is important, and many accidents could be prevented just by doing this. Many people would believe I'm young, but, well, I need the screen with a little bit of brightness to see it. I have presbytia, after the age of 50. I find it difficult, and it's not difficult to make a mistake with a pill. It's not difficult at all. Sometimes it's difficult to pick them. They're very small, some of them. And this is the day-to-day of normal people. So I would like to focus on those drugs you have at home. There are many. You accumulate them, and it's good to review them every now and then. Now, anybody from the audience would like to ask a question or make a contribution? Yes? Hi, good afternoon. You referred to the access by the chemist to the prescriptions. It seems interesting to me, but there should be a code so that only the pharmacist, the chemist, can access that information, no one else. What we cannot be is having a clinical record open, for anybody to see. Another thing that you could consider is the data protection regulation. Maybe. For some things we send our bank details over the phone, and then we protest for other things. But the data protection regulation is something that you would need to consider to see how you could be afforded access. And only with one code for the chemist, for the professional. From the Spanish Association Assisting Users, we work to promote the Charter of Rights and Obligations of Patients, and one of the rights is confidentiality. Sometimes access to the medical record should be given, but only for the cases where this is necessary. In this case, we're talking about electronic access to the whole medical history, including prescription information, and for sure we need to guarantee traceability, confidentiality. I understand that comment, because in a chemist there are many people working, and as a patient I want an assurance that only Pepe can see this information. I can understand your question. That the patient is the owner of the data, and the patient is the only who can decide who to share the data with. And of course, I want to share it with a person. It can only be with that person. I mean, the medical record being available to the whole chemist? No, only for one person. I agree. And there are laws and acts for everything, and the data protection regulation is a problem for us. I say so because sometimes, to conduct any study or anything in the chemist, we need to ask signatures. We need people to sign. Maybe for a survey. For research purposes, we need the informed consent. And then data, of course, that they are stored in a certain place under certain conditions. But I have peace of mind.
Sí.
Yes, for us, the electronic prescription, all public administrations follow a homologation or approval process. So all the information between ministries, doctors, and chemists is ciphered, and you need these codes. But these codes are for communication between the chemist and the system. But what you're saying is something different. What you're saying is having a code to have access to the data that the patient allows you to access. I agree. Dr. Baquero, would you like to add anything else? No. That's our aim. The patient is the owner of the medical record, medical history, and they grant or not access. Access should not be made available to the entire medical history either. You can check it as well. Never keep it or retaining it at the chemist. You will be able to check wherever needs to be checked. As a professional and authorized party, they will be able to check something. And also, if the chemist wants to make a comment, this bi-directionality, it would be great. It would be for the good. But the record shouldn't stay at the chemist. Maybe it shouldn't be all of it. I've been told we have run out of time. Yes, but there's another question asked. I don't want to be the baddie of the movie, but we haven't got time. I'm sorry. Can I make one comment to conclude this panel? Yes. Well, I belong to the Spanish Association assisting users, and talking about these things is something I love. In relation to what we referred to today, the ARTRO360 model, this is a model that is focused on the person. And the best thing we can do to focus on the person is to let them participate in the association or with the participation here, of your participation here today. This multidisciplinary approach is necessary for any matter to approach osteoarthritis or any other pathology. Patients should be responsible. You are all responsible and interested in this pathology. All of these initiatives provide value. When a patient feels they participate, they commit much more with their treatment and daily life. And I would like to thank you. Thank you for explaining this model, and thank you for providing this opportunity to explain things from the patient's side as well. Thank you.
Muchas gracias.
Thank you.
Doctor Baixauli.
Dr. Baixauli, don't leave, please. Not just yet. Because let me tell you something. Carmen, the lady, the treasurer of ECOSAR, of osteoporosis, had her hand swollen, and Dr. Vergés is trying to sort this problem out. But on behalf of Dr. Vergés, this is her sister, Maria Teresa Vergés, we would like to hand you this tree of life. Well, Dr. Baixauli, thank you so much for your help. The chemist is a necessary agent. Whenever we call you from Valencia, you come. Thank you so much.
Gracias, doctor. Bueno.